What's in the future for breast cancer treatments? Well, Dr. Raz is here today to talk about microwaving and freezing cancers in the duct. He's always a wealth of information, and we weren't expecting some of his projections and some of his predictions for the future. Listen and hear what he has to say. When you subscribe to our show, you help us grow. Someone you know may need to hear this story, so please share with your family and friends and consider supporting our mission at therose.org. Let's talk about your breast. A different kind of podcast presented to you by The Rose, a breast center of excellence and a Texas treasure. You're going to hear frank discussions about tough topics, and you're going to learn why knowing about your breast could save your life. Thank you, Dr. Raz, for joining us again. You know, I tell you that your episodes are always so popular, and today we just want you to talk about whatever might be on your mind or what you'd like to. One of the things I do want to ask you, though, is, you know, probably daily I have someone call me and say I was just diagnosed. They may not have been diagnosed here.
Right.
But they're a friend or, you know, someone I've worked with in the past. And they'll say, and I'm stage this. Mm-hmm. And what does that mean? Right.
So cancer, any form of cancer in the body, we tried to figure out, well, how big is the cancer and where has it gone? Because the basic, most simple definition of cancer are these cells are not in our control. So remember, every day the body makes new cells. So within your gut, cells turn over within a few days. Your nails grow, your hair grows. So skin grows, actually. So what is that? That is all under our control. It's a control, destruction, and regrowth in our body, right? That's how the human body is. When that system gets messed up, where few of these cells grow independent of whatever homeostasis we have in our body, and they're just independent from our control, our mind, or the process, or the system, and they're independently just growing and growing, and they don't care about anything else. That is what cancer is. Right. So in simplistic terms, that's what cancer means. Yeah. A mass or something in the body growing, and we cannot control it, and it keeps growing, right? Okay. So now that out of the way, you know, as physicians, we have to quantify, well, what subtype of cancer it is. Like, you know, there are many cancers that arise from different things. In breast, majority of breast cancer comes from the milk ducts, right? So the breast, the most basic breast anatomy is, well, you have these glands that produce milk, and then it's carried in these small ducts. The duct becomes big duct, and then duct opens up into the nipple, right? So the cancer, majority of the breast cancer is called ductal cancer or ductal carcinoma, and it arises from these pipelines or ducts, you know, call it. So that's the most basic thing. But then it's not enough. We need to find out, well, how big is the cancer and where has it gone? And we do not want it to go further than within the breast, because once breast cancer, in our example, gets to the lymph nodes in the armpit, then it's like a train station or superhighway. It can then travel to other places in the body, right? So staging is just a scientific or medical way of finding how far the cancer has gone, or where can we see. Now, in breast imaging, you know, it's a little bit complex, and they've just updated the staging system. Okay. So I'll just give you the simple way, and it may get it a little bit into the weeds, so you don't have to memorize, but you can listen to podcasts again, I suppose. Okay. But it's TNM staging. T stands for tumor size. N is for how many lymph nodes are involved, whether they be in axilla, and lymph nodes are everywhere. They could be in above the collarbone, called supraclavicular, or infraclavicular, just means above or below the collarbone. And they couldn't be in the medial chest. They're called internal mammary lymph nodes. So these are all lymph nodes around the breast, which could get affected by breast cancer. And then the M just stands for metastasis, meaning it has gone beyond this local regional area to another organ. So breast cancer, unfortunately, loves to go to liver, bone, and then brain. And then bone meaning, you know, backbone, so your spine. So tumor size, you know, let's say if the cancer is 0 to 2 centimeters, so anything under 2 centimeters in breast imaging considered a small mass. Okay. So that's the other thing I hear from women coming like, hey, I have this big mass. Really, not really. Even if you feel the mass is 2 centimeters or under, it's considered small mass.
Okay.
So take solace in the fact that even if you may have cancer, if it's under 2 centimeters, it's really a T1 cancer. Okay. And then if you don't have any lymph nodes, then that will be considered stage 1 cancer. Now, let me begin by saying that stage 0, previous podcasts we talked about DCIS. Remember, cancer that's in the pipeline, has not busted out, like a frozen pie that we get the Houston freeze, right? We're doing all these things so that you don't get the freeze busting your pipe. Same thing. The water is frozen, it's still inside, has not busted out. When it does that, then it becomes a mass. So if it's still in the duct, then it's stage 0, DCIS. Okay. Again, why do we do screening? Why do we do breast imaging? Because if you catch cancer, stage 0, it's completely curable. Survival rate is 100%. Okay, 100%. Stage 1 is also 99% 5-year survival rate. And this is where it becomes important. Staging, we've studied staging. It becomes predictive or prognostic, and we could figure out, hey, if you're a stage X, Y, and Z, how are you going to do 5 years, 10 years from now? Okay. And this is why it's important to stage and screen. Everybody gets your screening mammograms. Is because when you get it early, imagine if you catch a stage 0 or stage 1, you're not able to feel these masses. Only I can see them. Mm-hmm. Then cure rate is very high. Survival rate is near 100%, right? So again, going back, stage 1 tends to be masses that are 2 centimeters or under and no nodal metastasis. Or if you do have nodal metastases, that are micromets, like very small. Stage 2 in breast cancer tends to be masses that are 2 to 5 centimeters. So we consider 2 to 5 medium-sized masses. And you probably have 1 or 2 or 3 lymph nodes that are involved. That's stage 2, and then there's subtypes, stage 2B, etc. You don't have to get into too much detail. And then stage 3 tends to be bigger masses, so 5 centimeters or over, and then more lymph nodes are involved in the axilla. So 4 to 9 lymph nodes that are involved. And then stage 4 is just distant metastasis, where cancer has gone beyond the local regional. And the more important thing is, it's not just based on the size. The new guidelines now have incorporated what we call receptor status. So, plenty of patients come in like, hey, what should I ask my surgeon or oncologist? This is the important part. Where cancer wears different clothes, even breast cancer. And what I mean by that is every cancer has certain protein on top of it. And, some of these cancers we'll call estrogen. The names are estrogen receptor, progesterone receptor, and something called HER2/neu, which is a growth factor. And why is this important? It's important because whether you have ER/PR cancer or estrogen receptor positive or progesterone receptor positive has implications of how the oncologist will treat you. So there are medications that target this and then reduce and completely get rid of the cancer. And if you don't have it, then that's a different subtype of cancer. So more high-grade aggressive cancer. So these are relevant questions you should ask. Hey, what's my receptor status? And this is the cool part. Where let's say, like on the traditional metrics, what I just mentioned, mass is, let's say, 2.5 centimeters with no nodes. Classically, if you look up online, it will say this is a stage 2A cancer. But if the woman is ER positive and PR positive and HER2/neu negative, and again, HER2/neu being this special protein that cancer cells make that you can express or not express. So if you don't have that, then actually your prognostic staging is stage 1A. You get downshifted because you have favorable receptor status. That's what an oncologist will tell you. So the code word for that is saying, hey, you have these receptors, we can treat it better. And these medications are tamoxifen, aromatase. These are anti-hormonal therapies. So, when you use these medications, even if it's a stage 2 classically by anatomy, the size of the mass and the node status or how many nodes are involved, even anatomically, you may have stage 2A or stage 3 cancer. It gets downgraded into lower stages. And again, what's the benefit of it? Well, your prognosis is better, right? If you're stage 1, what did I say? You're 99% survival rate at 5 years. That's excellent.
Before we continue this episode, I have to let you know about something that is happening throughout this month of July. Our anonymous donor is at it again, and she wants to match your donation up to $100,000. So think about it. $20 is now $40, $100 is now $200, And if you're feeling really generous, $1,000 is now $2,000. Just think about all the women that we could help with your donation and our anonymous donors match. Please go to therose.org. It's easy to make your donation there. And as our donor said, every dollar counts. Now back to the podcast. So we as women really should wait until we know all that.
Correct.
And going to Dr. Internet is not always that great of an idea, right?
That's right. That's right. Yeah. Googling things. But you get to a good point that knowing this and asking these questions is relevant. Once you have this, it behooves you to research this, understand your own stage, and then ask, hey, is this my stage, to your oncologist or surgeon? And it's a little bit complex. It's not so straightforward because some women, who have larger masses, let's say 5 centimeters, they don't go directly to surgery. Mm-hmm. Sometimes they treat and they use fancy words. They'll call it pre-treatment or neoadjuvant. These are fancy words. You don't need to know that. You just need to know that, hey, I got some therapy before surgery. And the reason they do it is that to shrink the mass down, then they take you to surgery because, again, the benefit of downshifting or lowering your stages, you have better prognosis. Mm-hmm. You get rid of cancer faster. Treatment's better. So asking these questions to your surgeon and oncologist is important.
So you're asking about your staging.
Right, your receptor status.
About your receptor status.
Right, and then, frankly, what your prognosis is going to be based on. Yeah, and there are some other things that we look at, how fast, what's the grade of the cancer? That's another complicated, the grading just means how the cancer looks under the microscope to a pathologist. Okay. Higher grade just means the cancer looks more weird, for lack of a better word. Okay. You don't want that. You want lower grade. Mm-hmm. It also has implications of aggressiveness of the cancer. So non-aggressive, slow-growing cancer are lower grade. Aggressive, triple negative, or luminal B is what we call it. Cancer tends to be grade 3. So again, that would be a relevant question to ask. And any targeted therapies. So this is the other thing I want to get into. The future of breast imaging, if you will, or breast treatment is a lot of individual treatment. So targeted therapy is what the future is.
What is that? What does that really mean?
Right. So targeted therapy means that, hey, right now we know, let's say, ER receptor, PR receptor. They're already targeted because when you take tamoxifen, it's directly going and blocking those receptors. Okay. When you take a medication called Herceptin, it's directly going and blocking that HER2 new receptor. When you block it, cancer cells don't grow as fast. In fact, you get rid of it. It's like magic. If you do imaging on a patient like that, in 6 months, the cancer is gone. It's very good to see. So we find new receptors, new proteins that are messing up and the reason for which women get cancer. And whatever protein they make or cell abnormality, we try to target that, meaning go in and fix it. Okay. So, we've been hearing new, gene editing softwares, if you may have heard of these. Mm-hmm. These are all companies that are working on, and a lot of this is not right now targeted to breast cancers, to leukemias and all those cancers, but they're essentially re-editing these bad genes and making them normal. And they go in at this cancer cell level and figuring this out. That's right. So what I'm trying to get to is every day we find new proteins that are the reasons for which you get this cancer. And instead of just shotgunning and blasting all your cells with chemotherapy, we just find this one particular receptor and just blocking that with particular medication.
Interesting.
And
we shouldn't be afraid of this when we hear this genetic stuff that they're altering or
no, not at all. Not at all. In fact, it's almost magic medication because here's breast imaging also comes in. And maybe a lot of podcasters don't know this, but there's active research happening. You know how we do mammography, right, to do cancer detection. Understand that X-rays are great, but X-rays are ionizing radiation. These are high energy radiation that pass through us. Mm-hmm. And while there is no cancer risk, you're not going to get cancer from just doing mammogram or X-rays, it does increase. Let's say if you were to get 10 CTs in a year, you do run the risk of causing some abnormality and causing cancer, right? So high risk radiation continuous, we call it cumulative, is a risk. Okay, but it's just mammogram doesn't have much risk because it's such low radiation. Right. But what I'm trying to get to is there's microwave imaging right now. I don't know if people exactly, we microwave food.
Energy?
That's right. There's microwave breast imaging.
You're going to do that on a breast?
Right. So we're not putting it in our microwave, but the
I hope
energy.
Not. I
mean, all of these X-rays, ultraviolet rays, infrared rays, radio waves, microwaves. What are these? I'm getting into too much nerdy science detail, or light.
That's okay.
These are all electromagnetic waves, which are either very strong or not strong.
Okay.
Right? So you don't want to hang out in ultraviolet rays because they're very high energy, causes skin cancer, right? X-rays are also high energy, just not as high as ultraviolet rays. Radio wave, we're blasting radios all day, are very low energy. They pass all through us. That's why you're able to hear. It's all around us. It's not causing us any cancer because they're very low energy. Microwaves are the same. So don't think of the microwave that we used to. I'm about to eat a burrito in 5 minutes. But it's a special type of waves that we use to image the breast. But the cool thing is because it's microwaved, it's non-ionizing, not like X-rays. X-rays are ionizing. So there's active area research where we're going to put microwaves inside the breast, and then it reflects it back, and we have detectors that then detects, and then we make an image out of it, just like we make images out of X-rays. That's right. So it's an active area of research.
Wow.
So it would be non-ionizing, so that's already very beneficial, and then lots of groups are working on that. Lots of groups are also working on something called, theranostat. So what that means is, therapy with diagnostics. So think of cryoablation. I don't know if you've heard of it. So tumor, where you just go in and freeze the tumor. Right. So that's part of it, where you don't have to give patient chemotherapy. And the outcomes in some of this low-grade small cancer is better than lumpectomy. I literally go in with a tiny probe and just freeze the tumor, and that's it. That was your lumpectomy. You don't have to go through surgery, and cancer is cured. Wow. So that's what I'm talking about, the targeted therapy, where the way sometimes we do it in liver, you just go in with these microbeads that carry chemotherapy, and you're just directly going to the tumor and injecting it into the tumor. So you're not affecting the tissue around it. Right. So you can do the exact same thing in breast, where we just go in using ultrasound probe, and we have this targeted therapy and just inject it. And because it will have this special contrast that I can see under ultrasound, I know I'm going the right way. And then I'll confirm that the chemotherapy has been injected into the mass.
Is this out yet, or
it's not out yet? Okay. These are all. I'm going to the future of breast imaging.
Okay.
So these are all exciting things.
They're not as invasive. They're not as life
altering. Yeah. Chemotherapy, big side effects, right? I mean, you lose your hair, your gut flora is gone, trouble eating. Yeah.
You feel tired.
Lose weight. Cachexia.
Yeah. So many things that happen.
Right, because it's a generalized. Every cell is affected. Versus here, you do targeted therapy, and this is all thanks to everybody's heard of AI. It's everywhere. This is where it comes in, where AI is helping us figure out that, hey, what are these proteins? Speed up our research process. That's what all in the background. Everybody is using AI to write their essays right now to cheat the system or generate cool images or a chatbot or marketing, etc. But behind, in the background, AI really is helping a lot of researchers kind of turbocharge and shorten the time to reach their conclusions. And it's not out there, but a lot of researchers and faculty know of it.
So that's amazing. You mean 5 years from now, that close, we could...
Yes.
That would be how it's treated?
Right. It could be, yes. 5 to 10 years, yes. It's shortened the time, yes. So one of the implications, of AI is this. And then the other is, how do we define risk in breast imaging? So we know, so what are the risk factors for breast cancer? So being a woman, having advanced age, or if you had radiation or you had breast cancer, or genetic mutation. These are major risk factors for breast imaging. What are the minor risk factors? Well, honestly, like there are lots of papers and strong research and strong data to suggest obesity is one, right? So Dr. Malolo comes in a podcast, talks about sugar. She's not wrong. When you're obese, we found that, in postmenopausal women especially, fat cells are the ones that produce estrogen. And estrogen in postmenopausal is a big no-no because it causes breast cancer or uterine cancer. And that's where hormone replacement therapy comes in. When you're on it for long,
Right.
you cause it, right? So what am I getting to? Well, now obesity is a risk factor.
Right.
Smoking is a risk factor. But let's say a woman comes in, she has all these complex interactions throughout her life, or maybe she had kid not in her 20s and her 30s. That's actually a risk factor. Maybe she breastfed, but not breastfeeding is also a risk factor. So see what I'm getting to? Right now, our medical system is not equipped with like getting this detailed history. But you know what it can do it? AI can do it. Imagine your whole life's on AI. You're on the phone anyways. The AI thing knows, hey, when did you breastfeed? What did you do when you were a teenager? Because let's be honest, cell phones will still be around, these smartphones 10 years from now, 20 years from now, right? So it's your life history is there. What did you do at this moment? Did you smoke this amount? No. How much alcohol did you consume? What's your body weight, etc.? It will amalgamate all this information and automatically it will generate a risk score for you of developing breast cancer. We cannot do that right now. We have general models like Gale model that inputs some questionnaire answers or Tyre-Kruzak model, right? But it's not to the detail where an AI can come up with your own individual risk. That, hey, Dorothy, you have 13.5% developing breast cancer based on however you lived your life in the past 20 years.
Yeah, that's kind of scary, Dr. Raz.
No, but that's how it's going to be. The individual targeted therapy is based on this. And how can you achieve that? You need lots of brain power and processing. That's exactly what AI is, right? It's not us racking our brains out, but AI is going to just process all this. And in math terms, they call it multi-regression because it's taking all these random small variables, but they're all kind of important, but not important enough because they're not like the major risk factors, but important enough that it still gives you certain percentage of risk. So how do we quantify that? Well, AI will do that for us. And in the similar vein, on the therapeutic side, AI is the one that protein, it's literally going through 200,000 different types of protein and figuring out, okay, this works, that doesn't work. This works, doesn't work. Oh, this works. It would have taken us many years to find that one protein, but AI kind of does it really fast on its own, right? So we're finding new drugs faster. So that's on the therapeutic side, but on the risk factor side, it's also important because screening mammogram alone is not just sufficient. It's very good. It's the only study we have found to have mortality benefit, which is also the reason a lot of people don't want to give it up. And I don't want to give it up. But no, it's not the best thing for dense-breasted women. It's not. And we already know it's an independent risk factor. So what should we do for them? There is no good answer. Well, you know what? Once we have all this data, AI will give us a good answer. It will say, you know what? Based on your breast density, even though you didn't have first-degree relative as breast cancer, you're at 74.5% risk. You should do mammogram and ultrasound and try this abbreviated MRI. Or maybe, who knows, by then we'll have the microwave imaging. Maybe try this. Whichever way we can catch cancer early.
Right.
So this is all complicated. Yeah, so a lot of this is complicated, but it's all getting to the individual care that I'm hinting to.
Right.
So we kind of got from staging to here, but...
Hey, I think that there's hope. There's hope on the horizon, and AI is not the bad guy.
No, we can utilize it for excellent purposes, many good things, and it helps us. So yeah, so many exciting things that are coming for us.
See, I learned something else today. And
Microwave of the breast.
Microwave of the breast, yes.
Microwave imaging.
Oh, well, if that's going to make it better, we've got to be ready for it.
Right.
Thank you so much for joining us today. I know we're going to get some questions out of this.
Absolutely.
episode.
Happy to do another one.
Thank you so much.
You're welcome.
Thank you for joining us today on Let's Talk About Your Breasts. This podcast is produced by Speak Podcasting and brought to you by The Rose. Visit therose.org to learn more about our organization. Subscribe to our podcast, share episodes with friends, and join the conversation on social media using hashtag Let's Talk About Your Breasts. We welcome your feedback and suggestions. Consider supporting The Rose. Your gift can make the difference to a person in need. And remember, self-care is not selfish, it's essential.